Top Bed Talk.
Very unfortunately, John Moore, who leads the Prehab programme in Manchester, has COVID, so he is not with us today, which is a great shame. And he has sent Liam in his stead, so we're going to hear from Liam again.
Once I'm on the stage, you can't get me off.
Yeah, exactly. Liam is now going to talk to us about this project where we're hoping to engage everybody in the audience, trying to get some consensus about outcomes and standardisation of screening, assessment and intervention tools. Over to you.
Thank you. So, hello again. My name is Liam Humphries. So, why do we need standardisation? As we all know, Prehab is gaining widespread acceptance. We're all here today I hope there's no one in the room that's here because they don't like Prehab or don't think it's a good idea. So what we need to do now is start to think about how we can actually make sure that it is consistent to what we're doing, but also because it's now been introduced into clinical practice, is it doing what we intended it to actually do? However, as we've discussed today, there is some shortcomings in the current evidence. The research requires homogeneity in the data, and also we need to improve the quality of evidence that we actually have. So what we need really is we need to make sure that the assessments are individualised. We need to make sure that what we are delivering in terms of the intervention is reported clearly, and also what the outcomes that we are using. Are they monitoring effectiveness as we are intending them to? And also, are we using the best measures that we could possibly use to help patients through this? And that there is what we're looking at. This purpose of this talk is to start talking about this core outcome set that we'd like to start developing for prehabilitation. So in Sheffield in May 2022, we held an international prehab workshop. And within this workshop, my colleague Dr. Anna Myers collected data on the outcomes that 10 international prehab services used. And within these 10 services, so we had 5 different measures of physical activity. We had 3 different measures of quality of life. Carol earlier showed that, but EQ5D was by far the most popular. And also there were 7 different nutritional assessment tools as well. So to sort of make that point even more clearly, so within this review of prehab studies, it included 71 different studies. There were 625 individual outcomes used in those studies. The grey sort of lines on this show which ones were the most popular within those studies. So for example, at the top there, we've got the length of stay, and the blue lines there show that it was actually used mostly in abdominal cancers. But that slide there just gives you an idea of this sort of breadth of outcome measures that are currently used within the prehabilitation research. So, within this, what we are proposing is the development of a core outcome set. And here is an example of the development of what happens when a core outcome set is developed. And this is within rheumatoid arthritis. So you can see the arrow down here, so on the graph, which showed that which probably looks like 1994, where the core outcome set was delivered. And as the years have gone by, more and more research projects have used that core outcome set to where now more than 80% of these trials are actually using this measure. And that there can help these people in this research area to start to actually provide the data and use meta-analyses within their data to actually create large amounts of project and results that they actually make. So in terms of a core outcome set, just probably should define what that actually means. It is an agreed set of outcomes that should be measured and reported as a minimum within a field of study. So that doesn't mean that it takes away some of the creativity from designing your intervention or sort of the outcome measures that you're using. It just means that there is consistency then between projects that can actually be used. So the COMET at the top there, which is the core outcome set measures in effectiveness trials, is basically an initiative to help almost just organise the process of developing a core outcome set. So here on this slide is an example of how a core outcome set can be developed. So at the top here you have stage 1, where you do some desk-based research, so a systematic review, looking at what the landscape is in terms of the research in that area. But there's also some PPI work encouraged in this area. So starting to get, especially patients involved, to sort of look at what's important to them at this sort of stage. And then there is a Delphi process, which is what we're which will be setting up for prehabilitation. And what we do in this is where you get patients, healthcare providers, and experts together. You want quite a wide range of people to sort of start then categorising what sort of examples of outcome measures there are, but also what domains that they would look at as well. And then finalising that, you'll get a consensus meeting where people start arguing and bickering about which ones they think should be included and which ones they think they couldn't. And then they're not allowed to leave that room until they've decided. That's the dream, I think. But then you come up with a final key set of outcomes and standards by the end of that. So in terms of core outcome set studies, currently there are 141 core outcome set study sets in cancer research. There are 3 for cancer prehabilitation, and they're all in quite specific sort of areas, which are listed here. The bottom one, which is the DISCO study, which aims to develop a standard framework for people going through colorectal surgery. Within their process, they've narrowed it down to 6 different domains: physiological, life impact, global quality of life, adverse events, death, and also resource use as well. So in terms of what we are hoping to do, the process here is the UK Prehab Collaborative. And we'd like to co-design and propose an international standard of measures to be used in prehab research and also, importantly, service evaluation as well, ones that are actually being actively delivered in healthcare. So the measures will cover screening, so identifying patients' risk or level of need, assessment, so looking at what they start at baseline and also how that can inform people's support moving forward. And also, again, the key one, which is the outcomes as well. How do we assess the impact of what we are delivering? And the team, so we've got Professor Copeland, John, who unfortunately couldn't make it here today. We've got Shaman as well from the Royal Marsden, myself, and also my colleague Anna Myers. And then a whole roster of, so I'm not going to read everyone's out. So a lot of them are in the room today will help sort of develop this intervention, this core outcome set, But also the key thing here is that we want to work collaboratively with other international teams to look at prehab core outcome set to make sure that we are all on the same path, that we all are moving in the same direction. So here is just a quick example of how a core outcome set works. So this was developed for gastric cancer. So again, they did the systematic review and also they used patient interviews in that first stage, and also then obviously the Delphi process. Within that process, they found 498 outcome measures that they thought would be useful in this area. But they consulted with 942 patients and healthcare professionals. So it gives you an idea of the breadth of what we actually need to do to actually get these outcome sets in place. And then obviously they come then to the stage 3, which is determined how these outcomes should be measured. And they found these domains on the left-hand side here, which was surviving and controlling cancer, impact of surgery, and also complications as well. Thank you.
So, fantastic, because John and I developed these slides together. We met to discuss them, and Liam only found out this morning he was presenting. So that's fantastic. Okay, so we talked about outcomes. Now I want to talk a little bit about the reporting of interventions. And you've all seen these types of checklists. It's a checklist that has a minimum data set necessary to report the intervention. So you've seen things like consort to report a randomized controlled trial. So you know, when you're submitting your RCT, you should be submitting consort as well, the checklist, and it will include things like you can't just say you've randomized patients. You have to say that you've concealed them or not, concealed the randomization, and how that process worked. CERT is an exercise template. So if you did an exercise intervention, you can submit the CERT checklist, and it would include things on what the intervention was, how it was delivered, who delivered it. So it's all these kind of nitty-gritty reporting details. Now, why is this useful? It's useful when people are designing interventions because they can start with this checklist so that they know they're hitting all the key components. They know if they're designing an RCT that they should be considering concealing randomization and how that works. And it's also really helpful for the people who want to critically appraise the interventions to have this clear reporting of what was actually conducted in this intervention. And there's so many reporting checklists out there. If you go on Equator and you use their algorithm, you can see that if you're conducting a systematic review, you can use Prisma. If you're conducting an observational study, you can use Strobe. So there's tons of reporting checklists available to you, but not a prehab specific one. Do we need it? I'm going to just give you an example from a nutrition point of view. Myself and a few of the people in the room here, we conducted a scoping review of prehab trials. And of the ones that included nutrition, and about a quarter of those nutrition studies, we could not tell what the intervention was. So it said things like all patients saw the dietitian. So this is not helpful to the reader who is then, if you want to implement this in practice, how are you going to do that? You don't know what that intervention was exactly. We can't replicate that intervention. So if you think about length of hospital stay, let's say that this study that said all patients saw the dietitian reduced length of stay by 2 days. Now you want to do that in your practice, but you have no idea what that intervention was, so that's not helpful. And on the flip side, if you see this intervention did not reduce length of stay and you were expecting it to, you can't critically appraise and determine what that intervention was. Was that intervention sufficient? So when we're reporting interventions, the effectiveness of it is not just about the intervention itself, it's also about that implementation. We need to evaluate both to critically appraise and replicate these studies. This is work done by Dominique and Giuseppe. I think that they're here today. We had some clinical fellows join us at the Montreal General Hospital, and they went through 70 trials, RCTs, 70 RCTs of Prehab. That's how many we have. And they used all of these applicable checklists, all of these reporting guidelines to see how closely is the Prehab literature now reporting interventions according to these guidelines. And you can see for the consort, we're not doing too bad. So in terms of reporting our RCTs, we're doing a relatively good job of hitting all of those key components. But tidier, this is a checklist for reporting interventions. CERT, modified CERT is reporting exercise interventions. SPI is reporting psychosocial interventions. We heard from Liam that they're often not reported very well as either. If we had included all of these items together, on average, about 57% of these items were met for Prehab RCTs. So we're not doing a very good job of reporting our trials. Here comes SOS Prehab, standards for reporting research methods, interventions, and outcomes in surgical prehab. So we're now going to be conducting a Delphi, same process Liam explained, and we need all of you as experts. Maybe you're not all conducting prehab research right now, but you're still experts in your domain to contribute to the Delphi so we can develop this core reporting checklist, a core minimum set of items that need to be reported in all future prehab trials. So we hope that you will respond and participate in not just the outcomes, so developing core outcome set, but also in respond in helping us develop this checklist to report prehab trials. That's it. Thank you.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.